Good afternoon, everyone. I'm just giving another 2 minutes for people to join in so that we could begin. Today, we are going to have a similar mock exam followed by discussion on few selected cases by our faculty. So I'm just giving another 2 minutes time so that we can begin. Welcome back and good afternoon once again. I think we are good to go. Sriram, can you begin the PPT, please? The instructions are similar. You're just trying to keep it in a shorter format of giving you 3 minutes. So the key here is to make sure, read the question, really understand what is expected. So just to get into the tune of reading and expecting the questions and the required answers is something that we must practice. So if you can do it in 3 minutes time, I think you can jolly well finish everything perfectly all right in 5 minutes time. So sometimes you may feel there's excessive time left back, and sometimes you may feel that 3 minutes was not enough. But I think on average, we figured out that 3 minutes is good enough. So the instructions are going to be similar. You're going to be flashed, OSCE stations, and every 3 minutes we are going to have a different station. And right now of the presentation, I've requested Dr. Santosh Prabhu, who is a faculty as Hegde Medical Academy, to help discuss few selected cases. Dr. Divya, Ganesh, Nallur will join if she's free, but both of them have put together at least a good 3 to 4 days effort to make this sort of stations. And I really appreciate their efforts simply because amidst all their busy schedules and their training program, they've agreed to set up some stations for us. Yes, over to you, Sriram. Please run through it. All the best and make sure you do well. And we have very few days left for the exam, and I wish everybody the very best. Go ahead. You can run through the slides. So your time begins now. The timer is also on, right?
It's in the next slide, sir, with the questions.
Okay. So how long are you going to, put on this slide, Sriram?
Just 30 seconds, and then I'll shift it to the next one.
Okay. From that, once the question starts, you're going to give them three minutes time.
Yes.
Okay. Perfect. Right. Thank you. Go ahead.
Moving on to the next question.
Sriram, I was just actually thinking, probably if they want to read the question and actually analyze the required case scenario also, the first scenario could at least take, the first slide should take at least 40 minutes, 40 seconds or 45 seconds at least. You can cut down the timing on the question if you want.
Okay, sir. Okay.
So approximately 1 minute for the question, 2 minutes to respond to it.
Okay, sir. Okay.
Or 45 seconds at least.
Sure.
Thank you.
Moving on to the questions. Moving on to the next question. Moving to the questions. Going to the next station. Questions? Going to the next station. Questions? Moving on to the next station. Questions? Moving to the next station. Questions? It's break time. We'll start back when 1 minute is balance. We are moving on to the 8th station. We are moving on to the questions. We are moving on to the 9th station. Questions? Moving to the 10th station. Questions? Moving to the 11th station. Questions? Moving to the 12th station. The timer has already started. Moving on to 13th station. Time starts now. We are moving to the 14th station. Time starts now. It's break time. We're moving on to the 15th station. Moving to station 16. Moving to station 70. Station 80. Going to station 19. Going to station 20. Moving to station 21. It's break time. We're moving on to the next station. We are moving on to the next station. We are moving to the second last station. Moving to the last station. It's time, and we're done.
Hello, good evening, Mr. Sriram.
Good evening, sir. You can take over, sir.
Is Dr. Mahesh going to join us?
Your video is not seen.
Switched on my video here. So, is Dr.
Yes.
Mahesh going to join us?
I think he should be joining us. Maybe
Sure.
you can start, sir.
We can start. Good evening, everyone. I'm Dr. Santosh Prabhu. I'm the guilty party for having prepared some of those OSCE questions. And I've got Dr. Divya Nallur with me. Yeah, hi. You're muted, Divya, but that's okay. I mean, eventually.
Hi.
Just wanted to know from people how that OSCE examination went. There were 25 questions. You got only 3 minutes. Normally, you'll get 5. But sometimes you have to be prepared for a little bit less time, especially for cases like this. Can people either put a chat window as to how their exams went, how was his experience? Did it feel hectic or it felt relaxed? Yeah, I thought it would have been hectic, but the organizers thought it would be good practice for you to do it in 3 minutes. Yeah, I understand it probably was hectic. I would have preferred at least 4 minutes, if not 5, but time was not on our side and the examiners thought otherwise. Anyway, part of what before the preamble to this station I couldn't give. But one of this was to see whether you could write things down in that period of time and how you write the answers, because sometimes it is not good enough to know the answer, it's how you write it. It has to be aligned with the answers that the examiners write. And the people who correct your papers have only a certain leeway how much they can move laterally with regards to considering answers which may or may not look like the ones you've written. So hopefully you've done with that in mind. Last time we did a practice, I kind of said you have to be very particular about what you write, especially the use of abbreviations, the handwriting, and other things which sometimes we don't look into a great detail. But these are the things that matter and make the difference between getting, say, 50 score and 45. makes a difference. Divya, did you have anything else to add to that?
No, exactly. And the fact that you could do 25 questions, one after the other, you don't know what the next question is coming. And I think that was the whole point of giving you this experience of 25 questions back to back, because you could go from child to MRI to anything, and which is what will happen in your real exam as well. So just practicing that and being very concise and very specific about your answers is very important.
We thought we'd discuss a few questions. We could either pick questions randomly ourselves, or we could get you to pick them from the ones that you wrote. Some of the questions were written by me, some of them were written by Dr. Divya. So if you had any concerns, any questions about anything to ask about any question in particular, you can ask, and then we can talk about it. About one images and EEGs. I thought that would be. I'm very conscious of the fact that those are different, but again, we don't want this to be a theory class. We can get caught into that. Into that thing about teaching you EEGs and teaching imaging, which I think we don't have the time. So I'll discuss the questions that were there. But I think you should probably read. There is a good if you can search for some books on EEG, and there are some which are online. You might find it helpful. I'm just looking at one. It's titled Electroencephalography. It's a book by American Epilepsy Society. It's a 90-page book called a booklet. It becomes easier. It has got EEGs, standard ones, the non-standard ones, the difference between the two. And you don't have to read theory. It's all images and books. It covers EEG well. I think you can finish off EEGs within half a day, not even half a day, but a couple of hours with this book. It's a book by American Epilepsy Society. And again, for MRIs, online resource like Radiopedia is a good one. So just Google Radiopedia and then search for whatever images you want. You can put chronic subdural hematoma, you can put strokes, you can put Wernicke's encephalopathy, and images will show with a story, with an information about what that image is about. So just do a bit of online reading for things that you don't get. The name of the book is plain, straight, simple, Electroencephalography by American Epilepsy Society. What I can also do is perhaps share the book with the organizers, and I don't know whether they have a way of getting it across to you. Yeah, electroencephalography. Thank you, Vijay. Okay, so we'll just discuss a few. I'll share the exams and the answers. Just 1 second. Okay, can you see my screen? Yeah, so that's a book. Electroencephalography by American Epilepsy Society. If you want to have a look in that, it tells you all the basics of EEG, and then each page will have one EEG reading, and then it tells you what to look for there. Okay, so we'll just go through the exam questions. We'll go through some of them. Okay, so this was the question. I assume you might not have had too much difficulties with this one, so I'll just skim through this question. It's a story of a 67-year-old male. Let me just start this slideshow. So that's a 67-year-old, about a 67-year-old female, 2-month history of headache and decline in memory. This person has ischemic heart disease and aspirin and clopidogrel combination. Feels sleepy. So the hint, one of the hints was feeling tired most of the time. No history of falls and seizures. So that was a red herring. What you see here is a concavo-convex shaped hyperdense lesion, which is what is seen in subdural hematomas. The biconvex hyperdense lesions are usually extradural. The concavo-convex, remember a banana and an orange. The banana is subdural hematoma. The orange, the biconvex lesions are usually extradural. So there is a history of alcohol use, and the findings that we were looking for was for you to mention this concavo-convex hyperdense lesion, which appears to be a subdural hematoma. Now, if you want to ask what kind of imaging it is, it's a CT, and that is evident because the bone is seen as white. When you see the bony window, which is white, you know it's a CT, like an X-ray. CT is like an X-ray, it won't penetrate bone, so you see that as a white shadow. Anywhere where you see the white bone, it's a CT. Okay. Then other things are theory questions. What factors predispose to develop this complication? There were the fact that he's on aspirin. There is history of alcohol use, elderly person, and if you notice, there is a fair bit of cortical atrophy as well. So when there is cortical atrophy, a lot more space in the brain, a lot easily do the veins get bruised, and subdural hematoma develops quite easily. The treatment in this case, especially because he's been sleepy quite a bit and has been having disturbance of level of consciousness, you would want to do evacuation. Oh, sorry, these were the originals. I just go through these slides. These are what I had prepared. I eventually put them in this slideshow. Okay. All right. The next one was about this. Again, I'll be very brief because I don't want you to spend too much of time on theory. Here, it's an MRI. It's not a CT, and that's because the bone that you see is not white. So it's an MRI. In an MRI, the question is T1 and T2. Now, T1 is where white matter appears white and gray matter appears gray. So that's how you remember. That's how I remember it. T1 is gray matter appears gray and white matter appears white. So if the white matter appears gray here and the gray matter outside appears white, then it's a T2 image. So that's how I remember. And when there is such a degree of flare that is seen, these are usually flare images, which means it can pick up signal and accentuate the signals, especially when there is edema, when there is water, and so on. So the reason why I put this is because we had a case. Anyway, this gentleman is somebody who's brought in a catechic and require IV fluids and develop sudden inability to walk and develop horizontal nystagmus. What you see here is quite prominent flare-related attenuation in thalamus and the midbrain structures, and also in the periaqueductal gray matter. When you have a flare image which looks like this, your diagnosis is more or less certain to be wernicke's encephalopathy. Wernicke's. And because these are the high areas with highest amount of metabolism. So whenever there is thiamine deficiency, these are the areas that takes a hit first. The periaqueductal gray matter and the thalamus, mammillary bodies, and midbrain structure. So that is what I wanted to highlight in this one. Once you know the diagnosis, then prominent features you would know: wernicke's encephalopathy, global confusion, ataxia, and ophthalmoplegia, and definitive treatment, of course, is thiamine. Okay. I'm just having a look at my Zoom. I can't see the chat window. So if there is anything, Dr. Divya, would you mind just letting me know if there's anything in the chat window that people have raised as a concern?
Yeah, not I can't see anything yet, so I'll keep you posted.
Thank you. All right, EEG. Okay, what you see here is now people have said absent seizures because they thought this was triphasic waves. Now, while these look like 3 per second, not triphasic, but 3 per second waves, they might perhaps look a little bit like that. The clue was in the question that this person was brought in unconscious after a fall. Now, whenever there is unconscious, the person is not able to wake up at all. One of the potential diagnosis is status epilepticus, whether there was an epileptic attack and whether there is an ongoing epileptic seizure going on. And this is what it looks like, constant wave or spike and wave pattern in all the leads that you see. Every single lead that you see, bar occipital, you can see the EEG waves. So, when you see it's actually a focal seizure, but you don't need to know so much of details. So when you see something like this, you need to think about status epilepticus. So the questions that follow thereafter is on treatment of status epilepticus. How would we go about treating with an IV, lorazepam, midazolam, diazepam, phosphonatoin, whatever you can in order to terminate the status. The risk factors of the complications essentially are acidosis that can happen, anoxia that can happen as a result, and cardiac arrhythmias and electrolyte disturbances. So once you know the answer, it's easy then to take it thereafter. But the clue was in the story here, which says brief seizure followed by continued unresponsiveness. So one of the things again I would say is, today's session was not the session to do it because you only had 3 minutes. But in 5 minutes, sometimes you almost have to slow yourself down to read each question and each word in detail to know what are the clues in that. Every word that is posted in an OSCE is there for a reason. Words are not just thrown about; they are there for a reason. So you need to find out the relevance of each word in an OSCE station. So be mindful of that. Okay, this is another image. Again, an MRI because you see the bony window being black, not like what you see in a bone. And again, gray matter appears white and white matter appears gray. So it's a T2 image. The question here was the MRI findings, and you need to know there are only limited MRIs that can be posted. I tried looking for MRIs and CTs. I thought we could put in a psychiatric station. So it would be a stroke, it will be hematomas, it will be neurodegenerative conditions like and so on. It will be cytokine lesions. It will be one of the basic disorders like Parkinson's, Wilson's, Huntington's, etc. And perhaps strokes already mentioned. So these are the only things that can be put. So you can almost prepare a list of things that can be asked. And if you find a story which is like this, initial behavioral problems, then apathy, and then becoming clumsy and dropping things from his hand, you have to start thinking about whether it's a corticobasal ganglion degeneration kind of illness. There will be either Wilson's or Parkinson's or Huntington's or all those neurodegenerative conditions. And the age might give you a clue. It's probably not an age where they develop Wilson's. Wilson's would occur much sooner. 55-year-old, you'll either find Parkinson's plus syndromes or you'll find Huntington's, sometimes which can happen late. So in this case, it's Huntington's. And what gives the answer away is the almost flat caudate and how far the two caudates are. So distance, intercaudate distance is quite increased. So there's caudate atrophy, and that happens because the lentiform nucleus here gets compressed, caudate gets compressed, and they move away from the midline. So therefore, you find a lot of space between the two heads of the caudate. So that is a case of Huntington's disease. And then the answers follow thereafter, the genetic basis of the condition, specific medications for clumsiness, and so on. And some of the neuropsychiatric manifestations as well. In this case, again, you find dementia associated, there's apathy, there's irritability, there's depression, mood symptoms can occur, anxiety symptoms can occur. So those are the answers. Okay. I'll come to this, but I just ask if Dr. Divya wants to add anything, or if she wants to discuss any of the cases that she had presented, the first few, and if there was anything that you wanted to add.
I'm pretty sure that the clinical OSCEs that I prepared would have been pretty straightforward compared to the more neurologically tilted and image-related slides. But if anyone has any specific questions about any of the clinical slides, I'm happy to answer. I think they were pretty straightforward. It's a lot of it is just what you do in normal clinical practice. So I can't see anyone asking any questions on the chat either. So
there was one that I thought was a bit challenging. Yes, the heroin opioid dependence. Not many people have experience of managing opioid-related conditions in India. So from an experience point of view, I don't know if any of the PGs has had experience dealing with opioid detox. And
so yeah, if anyone wants any specific thing about the opioid detox, we can talk about it. The keys, someone's asked about, can we get the answer key? And we will give you the answer key, not to worry. Dr. Prabhu has prepared a slideshow of the answers itself. So, yeah. Can I have the questions?
Yeah.
To Santosh? Yeah.
Which one?
So what withdrawal symptoms you'd see in heroin or opioid detox is the opioid withdrawal symptoms would be, increased yawning, runny nose, runny eyes, diarrhea, loose stools, abdominal cramps, severe aches and pains in joints, and muscular aches and pains, and general irritability. So I had said 2 marks. So if you had written at least 4 of these constellation of symptoms, I think you would get the 4 marks. If it's a simple question, how I would mark OSCEs is, if it's a simple question like just write withdrawal symptoms, I would probably give half mark for every symptom you write. But if it's a very complex answer, then maybe 1 mark per answer you give. What investigations are useful in this case? I've given 2 marks. 1, urine drug screen, because you have to ascertain that it is, he had heroin in his urine, otherwise they might just be seeking heroin or opioids from you. So you have to do a urine drug screen. And because the question talks about occasional IV drug use, I would think checking for blood-borne viruses is very critical. So those would be the 2 things I'd be looking at. You can argue that renal function is important, liver function is important, but what is very critical in OSCEs like this is what is actually unique in this case and what are we looking for specifically in this case. And what options can we use for detoxification? So if someone comes with Ultracet dependence, if not heroin dependence, you have a few options. Even though we work in India and maybe methadone is not easily available to everyone except those working in AIIMS or certain prestigious institutions. If you do get opioid dependence, you'll have to do either a symptomatic detoxification with or without the use of lofexidine. So symptomatic detoxification is where you look after every single symptom. So if they are having severe diarrhea, you give loperamide. If they have abdominal cramps, you give buscopan. For aches and pains, you give something like Brufen or nimesulide or even paracetamol. For severe agitation, you might consider using benzodiazepines if they're not already addicted to benzodiazepines. So every symptom that they are suffering from, you try and give them relief from that symptom. Lofexidine is a alpha-2 antagonist, and it's used for detoxification because it decreases the adrenaline drive when it happens when the heroin or the opioid is removed. So lofexidine detoxification can only be done, at least I do it only if they are inpatients in our unit, because it does tend to, like clonidine, it's a sister of clonidine, and it tends to drop BP significantly, blood pressure significantly. So for monitoring and stuff, so we can say symptomatic detoxification with or without lofexidine is one of the options. And second option is you can just put them on some buprenorphine and then wean them off the buprenorphine in an outpatient basis. So you stabilize them on a little bit of buprenorphine and then start weaning them off over the next 14 to 21 days. What long-term treatment options can be given to this patient? Obviously, once you finish your detox, you can give naltrexone maybe to block all the opioid receptors. You can think about long-term rehabilitation options. And though, again, not available in private settings in India, but we can consider maybe long-term maintenance treatment with buprenorphine or methadone. Methadone obviously is not as widely available, but we do have a couple of patients who we do maintain on a small dose of buprenorphine to avoid them going back into opioid use. So those are the things that I was looking for in that question.
Okay. I'm just looking for any other queries.
They say question 17, Dr. Santosh. I don't know what is question 17.
Okay, so this is again question about a 22-year-old male with obesity brought in for poor academic performance. Was doing well until year 10 and has then become progressively lazy, they say. Sleeps most of the day, including in the class, drops his course, and has some problems with short-term memory. So this guy has done well till year 10, and then has, in quotes, become lazy, sleeps. Academic deterioration, he's put on weight significantly about that time, and daytime tiredness he's got. Feels unrefreshed and has a headache in the morning. So you kind of know that it's a sleep-related disorder. Parents report he's been snoring at night and does not report daytime breathing difficulties. Now, specifically, does not report daytime breathing difficulties to differentiate it from COPD or other heart-related conditions, right heart failure, which can sometimes have similar issues with regards to inability to sleep at night and so on. The other obvious hint was the father reportedly snores at night. And that's obvious hint because that is a huge predictor for the young guy developing obstructive sleep apnea. So that's what I was looking at. The young male, obese, doing well until a certain age, but then worsening after he put on weight, daytime tiredness, snoring at night, feels unrefreshed and has a headache in the morning, an occasional smoker. So all the findings that you would see in somebody with obstructive sleep apnea. The risk factors obviously are all the things that I said. The father having snoring, obesity, occasional smoking. So those are the risk factors. Differential diagnosis, just give me a second. I've written a standardized answer. Just give me a second, I'll get you the standardized answer so that it becomes very easy. Question 17, right? Okay, so these are the standardized answers. Obstructive sleep apnea. Risk factors being family history, male gender, yes, obesity and smoking. Differential being periodic limb movement disorders, which again is often comorbid with obstructive sleep apnea, present with exactly the same features as periodic sleep apnea. What happens is the moment they start going into REM sleep, they start having movement disorders which wake them up, and the REM they procure progressive REM deficits. Narcolepsy and sleep apnea syndromes. The one investigation that I would do to rule this out is sleep polysomnography, which happens in some places. I know in Mangalore there are 2 hospitals who do that. The advice would be to lose weight first and a CPAP, using CPAP machine, which gives a positive airway pressure so that the tongue doesn't fall, blocking your breathing. Okay, so that's answer 17. Let me just have a look at the chat window.
Question 20 was next. Question 20, question 14.
So what seems to happen is, Dr. Divya is a very kind examiner, and she has written reasonably exam type questions. Mind you, I have been very difficult. I have put very difficult questions, and I just wanted you to have a difficult test now and then have it easy later on. So all the questions that have been asked have unfortunately been the ones that I had. 14 it is. Okay, the one with Parkinson's. Okay, so see, this lady has Parkinson's. She presents with disorientation and agitation and some psychotic symptoms. She has visual hallucinations as well. She's on Syndopa combination, THP and ropinirole, which is a dopamine agonist. Whenever somebody with Parkinson's is brought with psychotic symptoms, the first differential is Parkinson's with psychosis. The second one is it one of the Parkinson's plus psychosis syndromes, Lewy body dementia and other things. The other thing that is very common is, somebody on 4 milligrams of trihexyphenidates in a person with a neurodegenerative disorder, developing delirium as a result of hypomnergic overload. That's a possibility. And last but not the least, all of these are dopamine agonists, Syndopa, ropinirole. There is with them causing psychosis. So that is something that we need to look at. And that's what I would do. Steps would take in assessing and managing a situation. Is it this? Is it this? Is it that? The medications I would prescribe, obviously, when you rule out delirium, when you rule out Parkinson's plus when you rule out delirium and other cause of delirium, and you have to treat the psychosis, your options are very limited. You have to use quetiapine, clozapine, or pimavanserin, which is a new dopamine agonist that has come, which does not cause extrapyramidal syndrome. So I'll just give you the answers. There it is. Okay. So somebody has written that thought of obstructive sleep apnea syndrome, but didn't expect this in psychiatry. Well, you would, psychiatry there's so much of comorbidity of obstructive sleep apnea syndrome, you will have to expect in psychiatry. If you were to go overseas and work, half your job will be, and I suppose here as well, is how to manage the metabolic side effects, obesity, and the fallout of other symptoms that happen as a result. Dr. Divya, there is a request for question 9, which is pregnant female with recurrent depressive disorder. I'll just get the slide up.
Yeah, so I changed.
OSCE. So that was question 9. Yes. Thank you. I'll get the answer
A
sheet.
30-year-old lady with a history of recurrent depression, 14 weeks pregnant, complaining of some anxiety already, and she's on 100 milligrams of sertraline, and has had severe postnatal depression following the birth of her first child. So we can get the questions. So what will be the current management plan? Basically trying to push you into, will you continue the sertraline or will you stop the sertraline? Is the question is asking you that. So will you continue it or not? The answer would be that if she's already a little bit anxious, you don't want to make her unwell, so you would continue. And what are the risks of untreated depression in pregnancy and the postnatal period? Again, pushing you to think about, though there are risks of treating depression with SSRIs in pregnancy and postnatal period, also thinking about what the untreated depression itself it will cause. So in the mother, it would cause lack of self-care, not going to appointments, lack of motivation to attend any obstetric appointments. And for the fetus itself, it's well known that maternal depression and anxiety can cause lowered birth weight, earlier delivery. So those are some of the risks that you have to write. We'll give you the answer key anyway. And which SSRI has the least risk of placental exposure? So I'm sure all of you know that, fluoxetine is probably most used SSRI in pregnancy, but according to a lot of guidelines now, including the Maudsley guideline, sertraline has the lowest potential of crossing the placental barrier. So the least amount of drug delivery to the fetus, the whole aim is that the fetus should get as little as possible, and the mother should be able to get the full effect of the SSRI. So for that reason, sertraline has started overtaking the prescription of fluoxetine across the globe in pregnancy. And now sertraline is mostly chosen in pregnancy and postnatal period. And for possible side effects in the newborn, some SSRI withdrawal symptoms, irritability, may be seen, especially if higher doses have been used. Some clinicians actually say withdraw the SSRI 5 to 6 days before the delivery, just to wean off the child a little bit, so that suckling and feeding, everything will become more easier post delivery. So SSRI withdrawal symptoms can be seen sometimes in. And very rarely, obviously there are some teratogenic potential. We can never rule it out. There is no evidence that it directly causes any specific abnormality, any of the SSRIs, but there is a small increase in chance of newborn abnormalities with the use of SSRIs, which can be mentioned in your answer.
So one of the question was, since sertraline is mentioned in the question, can it be repeated in the answer key?
Sorry? Yeah.
So, yeah.
Yeah, the current management plan, because you will continue, you will say, I will just continue the sertraline, because you can't really say you're going to change it to another SSRI. The lady has been on SSRI, she's been well on SSRI, there's little anxiety right now. So changing antidepressants right now is not a good idea anyway. So you wouldn't offer any other SSRI. Yeah, someone has mentioned that stop sertraline 3 to 7 days before and start again after delivery. Some clinicians do practice that. Yes, that is right, that pregnancy or delivery-related hypertension is supposed to be higher with the presence of the SSRI, but not all clinicians follow that withdrawal, and also it is said to be better for the baby, because it decreases the withdrawal symptoms from SSRIs.
Okay, I'll just go to question 20 because it's been asked by a fair few people.
Yeah.
Okay. Oh, sorry. Okay. So this is a 31-year-old man who was brought into the emergency department. I got it from one of the OSCEs that I prepared overseas, so that's why you see the name as taken. Forgot to remove that. Okay, see, he was sat in the car with the car motor running. It's unclear how long he was sitting there. Appears flushed right in the skin. So anybody who sits in the garage with the car motor running, the risk is carbon monoxide poisoning. We don't see that happening very often somehow in India, but it is not to say that we won't see it. You can get carbon monoxide poisoning from other ways, in which sometimes, earlier on, if you're in a house which has a wood fire, something like that, and things burn, and you don't realize it. So carbon monoxide poisoning can happen that way. The answer is here is flushed right in the skin. The cherry red appearance that you see is often as a result of carbon monoxide poisoning. Don't know, for 3 months, divorced from the wife, has been consuming alcohol on a regular basis for the last 3 months. And his mother died when he was young, and father, he doesn't have any contact because father emotionally and physically abused him and the older sisters. Now, cause for disorientation. Now, some of you, because there was history of alcohol use, I saw some of you sent the answers to me, and it appeared that as if some of you thought this was alcohol withdrawal delirium. But it could have been alcohol withdrawal, but the fact that there were other symptoms which pointed to carbon monoxide poisoning, like, for example, appearing flushed right in his skin. Alcohol intoxication is also possible, but then you will get an obvious smell, and that would have been in the answer. The key was saying that he was sitting in the garage with the car motor running, and it's unclear how long he was in that state. So then the questions follow thereafter are about carbon monoxide poisoning. Urgent investigation would be doing a carbon monoxide level. I don't know whether you guys have tobacco cessation clinics, but if you have a clinic in your hospital, all of you would have seen a carbon monoxide monitor. We have one in our college, and I suppose, if you have a tobacco cessation clinic, you would use it to look at carbon monoxide levels in the blood happen from cigarette smoking. Urgent investigations would be ECG and a CT head to find out whether there is anoxic brain damage and whether there is a problem with the heart. Immediate treatment is hyperbaric oxygen. And risk factors for suicide. Now that would have been a relatively simple clinical question. Divorce from the wife that is living by himself, presence of depression, consuming alcohol on a regular basis, death of the parent, no emotional contact with the father, and relatively high lethality suicide attempts. So these are, factors which somewhat predict for the risk of suicide. Hope that answers.
Someone asked alcohol intoxication, right? So with OSCEs, the trick is not to fit your answer to the question. If you want to fit alcohol intoxication into this question, you can possibly fit it, but it's to make sure why have they given 31-year-old? Why is it an emergency admission? Why is it in a garage? Why is the car motor running? Because all those will not make any sense for alcohol intoxication. And why is he depressed? There is no support, and there is history of mother dying, isn't it? Mother dying at a very young age. So we are seeing depression, we are seeing there's lots of reasons for suicide, and then there is a car motor running, there's a garage. So you have to make sure that the answer fits all of those parts and not just one or two parts.
I don't know how it is in UK, Dr. Divya, but here the DNB exams, OSCE exams are new. But how OSCEs are made is actually, these are OSCEs which are done by myself and Dr. Divya. We did it overnight or maybe in a few nights. And we haven't standardized them. Now, if we were sitting together and doing this OSCE, we would have looked at that. Now, the alcohol intoxication, yes, it is still an answer which I would want to think about. So I would have then, if we had standardized the question, I would have put something in that thing saying that he smells, there's no smell of alcohol, or he doesn't appear intoxicated. I would have probably put that. So be mindful that sometimes our questions that we prepare are not standardized. Hopefully, in your exams, you will get standardized question where there will be less ambiguity. So this is to say that we are not perfect in our in the way we prepare questions. We sometimes miss things like this.
And also, but also that they will try to catch you, because I remember my mock OSCE for MRC Psych. One of the stations was just get a consent. We had a actor for the OSCE, so it was just get consent for ECT. But there was a small line below saying your house officer has already gone and tried to take consent and she's a little anxious and you are going to recheck the consent. So there is something about it that is not just about taking consent. And I just took consent and I came back and I failed that station because the thing was I did not see why did the house officer not want to, just sign off the consent. It was because apparently the patient was going to say, yes, give me ECT, because when the house officer said there is a small chance of risk of death with anesthesia or whatever, she said, yes, that's the best thing you can do for me. So it was more a consent for suicide, like whatever, for death more than a consent for ECT. So they will try to catch you because that's the whole point of the exam. So be careful, read every sentence. Everything has some meaning in it.
Okay, maybe between 24 and 25, I'll do one. There was a question for 24 and 25. I'll just quickly see. Okay, all right. If you look at 24, it is essentially somebody who is brought in altered sensorium, has a daily alcohol use, past history of delirium tremens. That's all right. Last alcohol use was 2 weeks ago. Okay, when he stopped due to general unwellness. So 2 weeks after alcohol stopping, about 1.5 weeks later, he developed altered sensorium. So you can safely rule out alcohol withdrawal related DTs and alcohol withdrawal related seizures. EEG might trick you into believing that it is alcohol withdrawal related seizures or DT, but it's not. So what you see here are classic triphasic waves. And again, if you don't know what triphasic waves look like, look at that book on EEG. It will tell you how to differentiate 3 per second waves of absence seizures from triphasic waves, which is seen in metabolic and hepatic engine. And essentially that's what it was. These triphasic waves, you can see where my cursor is pointing. These are classic triphasic waves. Okay, one up, one down, and then one up, and then normal. Okay. So everything is theory-based. EEG activating procedures are things that you do. Things will be there on EEG: photo stimulation, hyperventilation, and sleep deprivation. Blood investigation for hepatic encephalopathy, you need to check for ammonia levels predominantly. That would be the predominant reason why people develop hepatic encephalopathy. And mainstay of treatment would be what you see in the they give lactulose, they give antibiotics to prevent infections or reduce gut bacteria-related production of toxic ammonia, and give beta blockers. So, and aspartate if you have those things. The next question is about, left side weakness, ability to speak, aphasia. and hemiplegia. Straightforward, it's a stroke. And again, as I said, there are only a limited number of neurology cases that you get. So that's a stroke, if you can see my cursor. There is a differentiation. The findings are that there is loss of differentiation of the gray-white matter. Gray-white differentiation is gone. Everything looks like one big blob. That's because it's all getting damaged from hypoxia. One interesting finding is this shadow that you see, almost like. So okay, somebody asked me a question: right side or left side lesion? Always remember, CT is when you see, you look at it from below. That's how I always understand. You look at CT from below, from their feet. So it's like section taken from when you are looking at them from their feet. So if you're looking at them from their feet, on your image, on your right is the left side, and on your left is the right side. You know what I mean? So this lesion is on the left side. But yeah, I was telling you about this little small dense lesion, and again, very rarely some examiners might ask you, not everyone. I was asked this question in the exams. It's a thrombosed vessel, and if you want to know exactly what's it called, it's called dense MCA sign or dense artery sign. Thrombosis, any of them. It could be an MCA, ACA, anything. So the dense MCA sign on the left. The dense MCA sign usually says that the thrombosis happened now, because if it's happened now, it will be dense. Thereafter, it liquefies. So if it's a dense shadow, then it's happened now, and you can give streptokinase or alteplase or whatever thrombolytic therapy you want to give. Okay, so that question is quite valid, and this is where standardization of OSCEs come into picture. So left-sided stroke shows right-sided weakness. So yes, so that's right. Rookie mistake. It should have been right-sided weakness, or rather aphasia I shouldn't have put, because if it's or left-sided, right-sided weakness and aphasia, yeah. You're right, Yashasri. This was that was a mistake. As I said, rookie error because of non-standardization. Anyway, immediate treatment options are streptokinase. You can embolize, and major risk factors for stroke that you would know anyway. Any of the atherosclerosis, hypertension, ambitious strokes, diabetes mellitus, smoking, hyperlipidemia, obesity. Okay. That's more or less what we wanted to talk about. Stop sharing. Yeah, so I think the standard of questions will be somewhere what Dr. Divya has put. Some of them might be curly ones. The reason why I put those ones are because I do not know for DNB how much exposure you have had with EEGs and imaging. And because the clinical exams has been replaced by this, that EEG and imaging will form quite a significant part of your OSCEs. So that's why I wanted to put it there. I think the rules for OSCE remain what I said at the beginning. Read question again and answer the question. There will each word is that OSCEs.
Close.
So hi, welcome, Mahesh.
Hello, Santosh.
Yeah.
Hello, Santosh and Dr. Divya.
Hello, hi.
Hi, so hope everything is up and done.
Yeah, we were just winding up. So I was just saying that OSCEs, you need to weigh up each word in that question will be weighed and put there. So be very mindful of that.
Okay.
and it will be all OSCEs will be standardized. Some of the ones we did today, you realized, I was just telling the participants that some of them might have a little bit of ambivalence in them, ambiguity. But the exam OSCEs wouldn't have that. They will be a lot more standardized than what we did today. Yeah, Dr. Divya?
No, I completely agree with what medication in normal grief, a Z drug just for sleep for some days, nothing else. Yeah, so I completely agree with you. Read every part of the question. Make sure your answer fits every part of the question, and leave the last OSCE behind. If you've not got it right, don't let all your other OSCEs go haywire. So, just keep moving and, be in the moment. You'll be fine. OSCEs are much, much better than long cases. You can score much more easily on OSCEs than on long cases. So, yeah, just do it now. It's almost done.
Yeah, and I think with the whole exercise in the last 3 weeks plus, what we've actually really tried to do is, get in this sort of orientation, because we've got used to MCQs to get qualified. Then we do the sort of long histories, which is written over 7-8 pages, and then give an exam. This time, both the things are taken off. You have something in between where somebody gives you everything and they'll ask you to formulate, probably ask you to respond to some questions related to case and management related issues. So understanding the question to the anchor point and making sure they know what the examiner is understanding is 50% of the work done, and putting down the relevant answers another 50%. We have 5 minutes. I think it's a lot of time. We're doing a lot of rehearsals and seeing. So 5 minutes is quite a good time. You'll have time. The moment you finish one station, the paper is taken off. You will not get a chance to go back to the station. So there's no use worrying about the previous station. So you'll have to move on. We don't have a choice. So are you guys done with the complete discussion of some selected questions that you had planned?
Yeah.
So I think it's my duty to thank you guys from the bottom of my heart, Dr. Santosh and Dr. Divya. I know amidst all your schedule, I kept asking you for questions, and you really struggled to balance this time and put in this 25 OSCE stations into place. And it is really time consuming. I know we're not just copying and pasting from somewhere else and doing a station here. So I hope the students really had the benefit of all the hard effort that you guys did. And when it translates to exam on Tuesday, I think the preparedness is definitely going to stand in terms of confidence for them. And once you're confident, I think a lot more things becomes easier for them in terms of scoring. And I would say this is the best chance for anybody to pass. So Corona can't give you a better blessing than OSCEs for you in that DNB exam. I'm sure we're going to outbeat the previous pass percentages. And thank you, Santosh and Divya, once again for the time that you contributed to this program. It's the second time I got you guys to do this program. So really thank you guys.
Thank you.
Thank you.
Thank you, Sriram, for coordinating this program effortlessly. And this is the last program. So thank you, Sriram, for signing off in a wonderful way. And Sriram has put everything on YouTube, and we have video recordings. So it's available for people to go back and review and see whenever they want. This PPT is going to go to them for practice, and the answer keys also can go to them so that they have something to fall back on. All right.
Okay.
So have a great exam and all the best. And please let us know your feedback, and please let us know your exam results also. We're very keen to know that too.
Yes.
Okay.
Yes. Bye.
Thank you.
Signing off.
Thank you. Yeah. Thank
Cheers.
you. Bye. Take care. Good day.